Hi, everyone. We are going to go ahead and get started. My name is Caitlin Neese, and on behalf of Tactile Medical, I want to thank each of you for joining us this evening. We would like to thank all attendees for the invaluable role that you all play in your patients' lives. Many of you bring hope to your patients, you champion their survivorship journey, and you make a lasting impact with every patient. So from Tactile Medical, thank you all for everything that you do. Tonight, we are joined by two esteemed panelists, Dr. Ron Carney, who is the Division Chief of Head and Neck Surgical Oncology at the McGovern Medical School at UT Health, as well as Brooke McGivern, who is an SLP and Head and Neck Clinician at Mercy Medical Center. She's also a member of the TIMS leadership team and an adjunct professor. We will start off with an exciting announcement tonight, and then we will hear from our panelists who will be discussing a multidisciplinary approach to treat head and neck cancer-related lymphedema. They will specifically be focusing on symptom identification, interdisciplinary approaches to documentation and clinical protocols, as well as sharing their real-world case studies. I did want to mention that before we get started, we will have time at the end for questions. So please submit any questions that you have through the Q&A. So kicking off, I did want to share an exciting announcement. We know that research shows that about 90% of head and neck cancer survivors develop lymphedema, and also research shows that about 82% of these patients are ages 65 and older. We all here know that all patients with head and neck cancer deserve relief from lymphedema. So with that, we are pleased to share that Medicare updates mean that more of your patients with head and neck cancer-related lymphedema may qualify for the FlexiTouch Plus. I'll pause there. This is just a monumental time for head and neck cancer patients, and it's something that we all should celebrate. So with that said, the following criteria that is listed here is required in order for a patient to qualify for the FlexiTouch. I did want to mention that we'll send this out to each attendee after the webinar for you all to reference as you are assessing your head and neck cancer patients. If you do have any questions on this announcement, we will be addressing Medicare-specific questions during this session. We will have Karen Shelton, who is our Senior Director of Government Affairs and Market Access. She will be on to respond to questions, and if there are any questions we don't get to, we will definitely respond via email after the session. So with that, I'm going to go ahead and hand things off to Dr. Carney, who is going to walk us through disease state and prevalence data.
Thanks, Caitlin. Good evening to everybody and welcome. It's always a great honor and pleasure to be invited to speak about something that I care about passionately, which is head and neck cancer and how we manage our head and neck cancer patients during treatment and even into survivorship. And I'm also delighted to be standing virtually alongside Brooke, who I've known for a long time and is an expert of experts on the topic as well. So welcome everyone this evening. Head and neck cancer is rising in incidence, as most of you know. And what makes this unique is that not only do we have an increase in number of head and neck cancers related to HPV, but we cure most patients and they will live a long time with the side effects of treatment. So there are something like 500,000 head and neck cancer survivors in the United States right this moment, probably more. It's a disease that affects men about 3 times more commonly than women. We can expect about 70,000 new cases a year. And folks do live 20, 30 years often beyond this into their 80s and 90s and suffer late and very late effects of their radiation. Next slide. And as you know, the lymphatics are part and parcel of the story of cancer, but also the story of the side effects. You cannot separate head and neck cancer from the lymph nodes because these cancers attack the lymph nodes in almost all cases. Once you have a cancer spread to a lymph node, you also need radiation. Once you get radiation and some other version, whether it's surgery or chemo, you've got extreme damage to the lymphatics. And this was not well understood until about 10 years ago. People thought you could live without your lymphatics and everything's fine. It turns out that's not true. And this damage leads to swelling, which is really the origin of the word lymphedema, edema being swelling. But that untreated lymphedema, that untreated swelling then becomes fibrosis, which is scarring. And so one of the things I always talk about when I talk about this subject is that this is really a story of prevention. This is like catching a diabetic early on in their course of their disease and before they need to have amputations of their legs and other terrible things. So in head and neck cancer patients, waiting until they get fibrosis is too late. All of this is part of a spectrum of the same disease that is lymphedema. Next slide. And there has always been the question of, which head and neck cancer patients have lymphedema. And we can say without question that the literature supports that it's at least 90% of head and neck cancer patients have clinically significant lymphedema. So I'm not talking about mild swelling above the scar after surgery that goes away after a month. I'm talking about people who have real life-changing quality of life affecting trouble swallowing, pain, discomfort, scarring, reduced range of motion, whether it's their jaw or their spine, implications on how they breathe. Of course, the swelling as well, but also the voice problems, and so forth. And so this fibrotic neck or this swollen neck that you see 1 month, 3 months, 6 months after the end of treatment is all basically a constellation of well choreographed sequences that lead to long-term devastating quality of life outcomes, which are preventable, which are treatable, and that's why we're passionate about it. Next slide. But we know that when it comes to the journey of a head and neck cancer patient, from the moment of diagnosis and through the tumult of scans and doctor visits, and then trying to make it to radiation 5 days a week for 6 weeks and getting chemo, trying to get answers to questions and so forth, we know that lymphedema kind of gets relegated to, the last thing that they need to worry about. And we have barriers here. This is why this work is so important. Because we have barriers. We have a treatment and we have a patient population, but this patient population often does not get this treatment. I have no doubt that everybody who's on this call at this hour of the afternoon and evening cares about this deeply. So we're preaching to the choir, but it's important to stop and think about why patients don't get appropriate lymphedema care. First and foremost, we don't have enough lymphedema therapists. We could double the number of lymphedema therapists 10 times, and we probably still wouldn't have enough. Patients often live in places where they don't have a lymphedema therapist who's an expert at head and neck cancer nearby. There are insurance restrictions. Insurances sometimes will say you can only have 6 visits, where lymphedema is really a long journey, much longer than 6 visits. It's not top of mind for hospital systems or even cancer programs. And then patients get a bit of an appointment fatigue. They say, look, I've got so many different appointments to make it. This one just doesn't sound important. And whose job is it to really explain to the patient why it's important to get lymphedema care? That sometimes falls between the cracks as well, where we sometimes forget, even on the MD side, to say, look, this is really important. This is part of your survivorship. And this is going to make a big impact in how you feel moving forward after treatment. Next slide. So in terms of symptom identification, this is not a far reach. Almost nobody who goes through, let's say, a typical tonsil or tongue-based HPV cancer treatment and goes through some version of surgery or maybe not, some version of chemo, maybe not, and usually radiation, they will, almost all of them have almost all these problems. And so it's not a far reach to try to figure out who's got lymphedema or when they have lymphedema. But the obvious monikers for this illness are obviously swelling. And sometimes we blow that off. The swelling in and of itself, patients can say, I'm swallowing okay, I feel better, I'm 4 months post-treatment, I'm back to work, I get it that I'm probably cured. And so even the patient can be a bit dismissive sometimes of swelling. But when you have external swelling, especially kind of in the submental area, that's really the tip of an iceberg of what's going on internally, where the radiation was aimed, where the surgery was aimed, where the cancer was destroying soft tissues, and where the problem is biggest. So that external swelling, even if the patient is brushing off the rest of these symptoms, is a real thing. Of course, the skin changes, the fibrosis, the scarring, the thickening, pain. Pain is a really important one. Tightness, range of motion, again, whether it's mandible or spine or larynx. Laryngeal mobility is super important, laryngeal elevation. And then the one that I think is probably most important in the context of lymphedema, which is trouble swallowing. there's no question that good lymphedema care improves swallow outcomes. And we're going to show you some of that data later. It's been proven now. I couldn't say that to you 5 or 10 years ago, but that's now shown. And so a lot of patients will come back and say, I've got swallowing problems, but the doctors are not connecting the dots between swallow problems and lymphedema care. There is always, I always say, two critical things that must happen to a head and neck cancer patient after radiation. One is a speech and language pathologist, and the other one is a lymphedema therapist. They have to have both. If you don't have both, you haven't set the stage correctly for good recovery. If you have just one and not the other, a lot of patients will fail. Their feeding tubes won't come out. They'll be limping along with a bad swallow for a long time. And the rest of these things on this list, some of them can be quite impressive, like airway obstruction. In some patients, appropriate lymphedema care can actually help get their trachs out, so that because it helps improve the airway by decreasing internal lymphedema, of course, speech and breathing as well. I'm now going to ask my friend Brooke to pick it up from there and tell us a little bit more about what she sees.
Thank you so much, Dr. Carney. Now we will transition into discussing external and internal presentations of lymphedema that Dr. Carney just touched on. So as you all are probably well aware of, patients and survivors of head and neck cancer may vary in lymphatic presentation based on the progression in the disease state. On this slide, we provided a variety of presentations that you might see externally in your own practice. At the foundational level, I recommend that clinicians look for edema and fibrosis in the submental region, near the cervical spine, and in the face, in addition to the skin changes that Dr. Carney just touched on. Additionally, patients may present with issues moving their head and neck side to side, which can impact vocational responsibilities and ADL, such as driving. Additionally, patients may present with reduced jaw range of motion, impacting mastication and communication. Further, if you are working with a patient at the bedside or maybe in the outpatient setting, you might be looking inside of their mouth and noticing that they have reduced tongue range of motion, which can impact both communication and swallowing. These symptoms are all in addition to the frequent reports of difficulty swallowing breathing that Dr. Carney just touched on. So as you can see on this slide, patients with external lymphedema may present with different symptoms as well as external presentations. If you're considering palpation, if a patient is in an earlier stage of lymphedema, you may note that manual pressure results in easy fluid displacement. So I want you to envision putting light pressure on a loosely filled water balloon or water bed. This is similar to what you might feel when applying pressure in an earlier stage of lymphedema. Contrast that to later stages in which pitting edema is noted, or when the application of pressure results in minimal to no movement. Next slide, please. So next, we are going to discuss internal lymphedema. As you can see on this slide, again, patients may vary in presentation of lymphatic dysfunction based upon disease progression. When we are able to obtain endoscopic imagery over the course of time, we can visualize disease progression internally, similar to external progression. I will note that research demonstrates patients may present with internal lymphedema without having any external lymphedema. Therefore, in my opinion, endoscopic imagery is absolutely critical. In the photos in the top line shown here, you can see examples ranging from mild to end-stage lymphedema where fibrosis is present. In the photos along the bottom, I've provided again a variety of internal lymphatic presentations. For those of you working with disciplines that can obtain endoscopic images, I highly encourage doing so. Endoscopy can help provide imagery to support the benefits of external techniques such as manual therapy, compression garments, and advanced pneumatic compression. Additionally, I want to note in my own experience that there have been times when I'm reading a patient's chart and see a description such as visualize expected post-radiation changes to describe internal appearances as demonstrated along this bottom line of images. I did include an endoscopic image in the top right-hand corner that is normal. So if you have not seen endoscopic images before, that's your reference. Normal up in the top right-hand corner, and then the abnormal there, throughout the slide. So for these reasons, because we're seeing in the charts that this description of expected post-radiation changes, I do encourage that you obtain endoscopic images for anyone in the rehab setting, because these images can provide insight into swallow function, voice, and airway integrity. In my own practice as a speech pathologist, I've often used endoscopy to demonstrate to patients and the interdisciplinary team the benefits of external interventions. So for my colleagues in the PT and OT departments, endoscopy can really help validate what you're doing externally. Finally, for my colleagues who are performing endoscopy, I encourage using tools such as the revised Patterson scale to assess internal lymphatic changes in collaboration with other members of the team to strategize management options. Next slide, please. In addition to endoscopic imagery, fluoroscopy can help provide quantitative data regarding internal anatomical changes secondary to external interventions. For my colleagues who are performing video fluoroscopy or reviewing video fluoroscopic images, at the foundational level, I recommend assessing changes in the submental region, the epiglottis, and the posterior pharyngeal wall. Greger and colleagues recently published an initial proof of concept study in which quantitative measures via TIMS MVP were used to assess internal anatomy. Dr. Carney will discuss this in depth later this evening. However, for those performing video fluoroscopy, you can use this publication as a reference point for anatomical areas to assess using fluoro. As you can see in the images in this slide, patients again may have a variety of presentations. And looking to the photo on the right-hand side, this patient had significant internal lymphedema causing swallowing impairments. Unfortunately, he had lymphedema both internally and externally, which impacted his ability to complete compensatory strategies. You can note this in the photo depicting his inability to perform the chin tuck due to external lymphedema. Next slide, please. As we've discussed, lymphedema is chronic and progressive, which is why you may see a variety of presentations within your own caseload. I cannot fail to mention that prevalence, as Dr. Carney already touched on, is extremely high in this patient population. Recent publications by Jeans and colleague report that 96% of people with head and neck cancer will develop some form of lymphedema. It may be internal, external, or both. On this slide, you can see the stages of progression from stage 0, in which there is no evident edema, to stages 2 and 3, in which fibrosis has developed. It is vital that we intervene as soon as possible. Based on the prevalence data, the question is not really if the person will develop lymphedema, but when will the person develop lymphedema. We know that patients have improved success when intervention occurs earlier and that the burden of management is reduced. For this reason, I recommend education and intervention prior to the development of lymphatic dysfunction whenever possible. However, as we all know in the real world, we know that this is not always possible. I'm often asked, is it too late to provide lymphedema therapy? And my response is always, it's never too late. If we can help alleviate even one symptom of burden for a patient, therapy is absolutely worth it. Next slide, please. So now we are going to transition to case studies. I'll have you forward to the next slide. Awesome. In this first case, the patient was diagnosed with squamous cell carcinoma and treated with radiation and chemotherapy. He was not referred to SLP services until approximately 1 year after treatment. He presented with severe oropharyngeal dysphagia, severe trismus, as well as internal and external fibrosis. As a result of these ramifications, the patient had been PEG dependent for 1 year, experienced social isolation, and had suicidal ideations. Additionally, these issues resulted in financial ramifications, including loss of work. Treatment was completed by both myself as a speech pathologist and my occupational therapy colleague, and treatment options included a multimodal approach with daily use of FlexiTouch, manual techniques, stretches, compression garments, and progressive overload using both exercises and a bolus-driven approach. Manual techniques were completed both intraorally and externally. In the photo here on this slide, you can see the patient's progress externally over 2 months. I will have you note the improvement in tissue integrity, including color change and the reduction of pitting. Additionally, you can more clearly see the patient's jaw. Internally, anatomic presentation and function also improved. NBS results revealed improvement in both safety and efficiency over the course of 12 months. By the conclusion of intervention, speech intelligibility had improved to 85%. All nutrition and hydration were able to be obtained orally. He was able to fully return to work, and he resumed cooking for his family, which was one of his personal goals. Next slide, please. Moving on to our second case. Again, this patient was diagnosed with squamous cell carcinoma, which was treated with radiation and chemotherapy. He was referred to the speech pathology team during treatment. However, this case occurred during the COVID-19 pandemic, which impacted the patient's ability to access outpatient services consistently. Unfortunately, the patient developed severe internal lymphedema, which, as Dr. Carney mentioned, can result in trach placement. And in this patient's case, he did have to have a trach placed. Due to internal and external lymphedema, among other factors, the patient developed severe oropharyngeal and esophageal dysphagia. Additionally, he experienced significant stress, reduced quality of life, and was forced to file bankruptcy due to the immense number of medical bills. Treatment was completed by both myself as a speech pathologist and the occupational therapist, and again included that multimodal approach I just mentioned, which included flexi-touch, compression garments, internal and external manual intervention, stretches, and progressive overload, again using boluses and swallowing exercises. The patient did achieve decannulation, his peg tube was removed, and he returned to a general diet and thin liquids with compensatory strategies as needed. We celebrated his success with a Boston cream pie, which was a really awesome day. Next slide, please. All right, moving on to our final case. Again, squamous cell carcinoma treated with radiation and chemotherapy. This patient developed severe internal lymphedema as well as external lymphedema. He was not referred to SLP or CLT services during treatment. After treatment concluded, he began to complain of swallowing issues and was referred to GI for dilation. In the days following dilation, the patient began experiencing increased issues with both swallowing and breathing. These issues resulted in repeated ER visits. He was then referred to the SLP team and subsequently the CLT team. He was PEG dependent for several months at this point, and these issues resulted in high stress within his relationships, financial ramifications, and social isolation. And you can go to the next slide. Treatment was completed by both physical therapy and speech pathology. The approach implemented was again multimodal using flexi-touch, EMS T150, manual interventions, stretches, kinesiotape, low-level laser therapy, compression garment use, and progressive overload using a bolus-driven approach and swallowing exercises. Additionally, repeat dilation was beneficial. Results demonstrated improvement in swallow safety, efficiency, improvement in external and internal lymphedema, increased expiratory strength, and eventual peg tube removal with the patient consuming an easy-to-chew diet and thin liquids. He celebrated his win by tailgating at a Chiefs game. And with that, I will turn it over to Dr. Carney to further discuss treatment options.
Thank you, Brooke. So, when we think about lymphedema as a problem and how we treat it, the gold standard is sitting in front of a lymphedema therapist and getting educated and getting comprehensive decongestive therapy and skin education, and then ultimately being taught how to do self-MLD. That's really the gold standard, and it should stay the gold standard. One of the great challenges, like I mentioned earlier, is actually doing self-MLD. Patient compliance is poor, and they don't always do it, and then they don't see the lymphedema therapist again for maybe a week or a month. And then other patients can't get in with the lymphedema therapist because that lymphedema therapist is busy doing twice a week with one patient, and their schedules get full. And so the whole idea of pneumatic compression actually came about in the breast cancer world and has been demonstrated in that space time and again to be really an adjunct to that first episode with the lymphedema therapist. And the way pneumatic compression works is that you have these chambers and a vest, and these chambers inflate and deflate and give you really an opportunity to do something at home that has very high compliance. And in fact, one of the things that this device was geared towards is solving this compliance issue. And we've looked back retrospectively at patient-reported outcome studies and shown that the compliance is about 90%, meaning 90% of patients who get this device will use this device every day. And that's really the advantage of adding pneumatic compression to what was historically a visit with a lymphedema therapist, and then some education, and then hopefully you can get this done on your own. And a lot of times things just kind of fell apart. Next slide. So the FlexiTouch is clinically proven. We'll talk a little bit about that here also. You can do it at home. You can do it on your time. We always recommend it in the morning when lymphedema tends to be worst, but some people wear it twice a day. They feel like it helps them sleep better at night as well, and there's some anecdotal reasons why that might be so. It's consistent, meaning that it doesn't really rely on the patient understanding your self-MLD instructions and actually doing them. It's convenient. You can do it in your own living room or in your own bedroom while watching TV or checking your kids' homework or just resting. And it feels good. One of the things that's interesting about this is that it's actually quite a comfortable experience. So there's nothing adverse that drives patients away from this. And this is not novel treatment. In the head and neck space, we're really following the breast space. And if you think about it, breast cancer patients have surgeries to the breast and the axilla. They get radiation with the same machines that head and neck cancer patients get, and they get downstream effects to their arm. In the pelvic, there's a similar paradigm, and in the head and neck, we see the same. The difference in the head and neck is the implications for the functions in the head and neck, again, like swallowing. And it's quite, like I said, it's quite a comfortable, soothing, massage-like experience, but it is driven by very rigorous science. So let's talk about that science a little bit here and jump over to the next slide. The study that I'm most excited about, and I have to say, the champion of this is actually on the line. So good evening, Jessica. We're all big fans, but Jessica, by way of introduction, wrote this paper and executed on it. And what this was really the missing piece in terms of the story of swallowing and head and neck cancer related lymphedema, and specifically this treatment of head and neck cancer related lymphedema. So what Jessica did was ingenious. She took patients who were getting a regular modified barium swallow, and she interrupted the MBS about halfway through, did 30 minutes of pneumatic compression, and then finished the MBS that she had already started. And by doing it this way, the design was brilliant because patients become their own controls. So we're comparing apples to apples. We're comparing Mr. Jones before and after 30 minutes of pneumatic compression. We're controlling for all other factors, and we're just looking at an MBS and seeing if anything is different after doing so. And when I say we, I really mean Jessica and her team. And what's most impactful about this study, next slide, is that almost every factor that they looked at, in terms of the size of the neck or distances seen on the fluoroscopy, like the width of the palate or the epiglottis or the posterior pharyngeal wall, all of these metrics that you see here in front of you all reduced, meaning for those of you who must have an immediate gratification, I'm one of those people, I'm guilty as well, you get immediate gratification here. You immediately will see, on average, a mean reduction of 10% at the level of C2 on the posterior pharyngeal wall, for instance. And so she was able to demonstrate really something that's very important from the biophysics of this disease, which is that the internal lymphedema is affected by external manipulation. Now, most lymphedema therapists will tell you, well, of course it is. We all know it is, but you have to know that sometimes I speak to the skeptics. And the skeptics will say, how is it that external pneumatic compression or external MLD impacts internal function or internal edema? And the answer is it does. That's another whole book of science we can talk about another day. Studies that were done with indocyanine green and so forth. But suffice it to say, the bottom line is Mr. Jones, 30 minutes of lymphedema treatment with pneumatic compression. Mr. Jones now has all these reductions in edema, and this is commensurate with what Mr. Jones is telling us, which is that he feels less heavy, that he's swallowing immediately better, that he's breathing better, that his voice is better, that his head doesn't feel as heavy, that he doesn't feel as swollen or look as swollen, all those functional aspects as well. Next slide. And we know from this study that what I just described there, so they feel better, decreased swelling, decreased pain, swallow is such a big one, fourth column, but that's huge. In these patients, the ability to sit down and have Thanksgiving dinner with their families is huge. Range of motion, the skin changes, and was the treatment comfortable? 100% say it was. So there's kind of a real incentive to do this. People go home with instructions all the time, take this medicine, do these things, and a lot of times they're not compliant. But here, patients want to be compliant because they feel better and the treatment feels good. And that's really important. Next slide. And so some key discussion points that came out of Jessica's important paper is that the presentation of external lymphedema and fibrosis could be very subtle. And I think Brooke touched on this before, which is that, you could, if you look, you'll find it, but you can catch it in different stages along this choreographed constellation of findings. So you might be looking at a patient 2 months post-treatment and they're convincing you that they're doing great. And they probably are, because their acute toxicities are gone, but the chronic ones are just starting and they feel better than they did 2 months ago. But that doesn't mean that there's nothing going on or there's nothing that's evolving to become a problem down the road. And we know that healthcare providers are notoriously bad at stopping to ask the questions and to look for these symptoms, especially the internal lymphedema, which is, like Brooke described, often there, but is relegated as kind of expected post-treatment changes when there's nothing expected about having all this edema, and that we know we can affect this edema by treating it. So it's not normal to say you're swollen after treatment. It's abnormal. And so it's not, we expect this, we see this in everybody, we see this in everybody, and we tackle it in everybody. And so even in patients with very late radiation changes with fibrosis, there are some improvements in these patients. And the late patients who were irradiated 10 years ago, who are coming in with new problems now, there is an opportunity with pneumatic compression to address some of those problems as well. And then final slide, I want to pivot from Jessica Greger's good work, thank you, Jessica, to another amazing group that asked another important question. This is from Barbara Murphy and Sheila Reidenauer, where they did a randomized controlled trial, so kind of the best kind of study you can do, looking at advanced pneumatic compression versus what they called usual care, which ended up being primarily self-MLD for head and neck cancer-related lymphedema. And we don't have to go down into the weeds of this whole study. It was a very complicated study and very carefully designed and took a long time to do and is published. So it's out there in PubMed, you can find it. But basically they found that the lymphedema, the swelling, and the pain all were decreased in the pneumatic compression group relative to the group that was just doing self-MLD at home. And the p-values were all less than 0.001, meaning that this is real, rigorous science showing the benefit of pneumatic compression over just relegating a patient to, we'll see you every 3 months and do some self-MLD. So this is really important science. So next slide. So I'm going to ask Brooke now a question, since I've known her for a long time, but we'll turn to Brooke and we'll say, Brooke, what do you see as important now that we've set the stage on this topic of lymphedema? But we have to bring the story of lymphedema back into the clinic. So you've got busy surgeons, busy med-oncs, busy rad-oncs. Where along the story of a patient's cancer journey can we or should we stop and answer the question of, do you have this and are you getting the appropriate treatment for this? So Brooke, I'll turn to you.
Yeah, thanks, Dr. Carney. So he brings up a great question, and he actually mentioned this at the beginning of the presentation this evening, that this is really a question of prevention versus reaction. So in this photo, you can visualize an example protocol which implements early intervention for people with head and neck cancer, which highlights the importance of being proactive and having a multidisciplinary approach. Within my own practice, I've helped develop similar protocols within multiple systems, but this example was provided by a fellow speech pathologist that I've worked closely with at the Cleveland Clinic. So to answer Dr. Carney's question, in my clinical opinion, I think that we should really be involved at the time of diagnosis. In my former clinical practice, I was a part of the tumor board, and I would sit in with the CLT, and we would go through every case and make sure every single patient was referred at the time of diagnosis for both speech pathology and CLT services. So we would actually implement therapy early on in the process, sometimes even during head and neck cancer treatment, and get the ball rolling in terms of referrals for some of those home treatment options like compression garments, FlexiTouch, and some of the other treatment options I mentioned in the case studies. So in my opinion, I think prevention is key. I think the earlier we can get in and provide education, counseling, and information, the better. This really helps support patient autonomy and helping patients to be in the driver's seat of their health. So with that, we'll go to the next slide to answer another question that we are frequently asked, which is, who takes ownership? Often the ownership of head and neck lymphedema comes into question of, who should take ownership of evaluation, treatment, and management. In my opinion, everyone on the team really should take ownership, because each discipline has an important role to play in lymphedema education, counseling, and intervention. As we've already mentioned during this presentation, imaging like video fluoroscopy and endoscopy can be leveraged to demonstrate benefits of external techniques such as manual lymphatic drainage and flexi-touch. Physicians and speech pathologists can help provide the endoscopic imagery beneficial in guiding intervention for both physical and occupational therapy. Additionally, nursing can help provide education and counseling. Dietitians can help with nutrition recommendations to support caloric intake while reducing upper airway inflammation. As Dr. Carney mentioned, our physical and occupational therapists are absolutely key in patient not only recovery, but overall wellness. And then, of course, our colleagues in ENT and GI are absolutely vital to patient success. And, in summary, we are all needed to support holistic care. In my opinion, at the end of the day, patient success can really be supported by each member of the team. And although each setting and system is different, as Dr. Carney mentioned, the most important factor, in my opinion, is that patients receive that education and information to make informed decisions. We haven't talked about this publication yet, but recently Dr. Stubblefield and Weicker, they had a publication in which they reported that head and neck lymphedema is understudied, underrecognized, underdiagnosed, and undertreated despite the growing body of evidence that successfully addressing it in head and neck survivors offers a multitude of benefits. They further go on to state that if we do not address lymphedema, it may result in fibrosis. So each of us on this call this evening can play a vital role in helping these people not only survive cancer treatment, but to live life well after treatment concludes. So with that, I'll turn it back to Dr. Carney and ask, do you have anything else to add on this topic?
I love everything you said, Brooke, and I'm going to take it a step further on this question of ownership, because I think this is actually the call to action, and everybody on this call is somehow involved in the story of lymphedema, I'm sure, or in the cancer patient's story as well. The slide that you showed 2 slides ago was talking about the importance of speech and language pathologists and lymphedema therapists. And I think that this really brings up the question of pathways. The best cancer practices in the country are not the ones that do, some kind of fancy new technology per se, or really the ones that do the best job are the ones that can move the patients where they need to be at the right time, meaning you need to be seeing a surgeon, or you need to be seeing a med-onc, or you need to be seeing a rad-onc. Of course, that's a big part of the process in the beginning. But how important is it to see a speech and language pathologist, even if you're swallowing perfectly and you have a small tonsil cancer, but you're about to start radiation? It's really important. It's actually probably the most important differentiator between good and bad cancer practices, because everything else is quite standardized. And I would say, like I had said earlier this evening, that the lymphedema protocol needs to run alongside the speech and language pathologist protocol. So we could make 100 slides about it, but it's actually quite simple. If we were to ask, what are the best cancer programs in the country? It's the ones that make sure that a patient somewhere in the early part of the journey, so when they're diagnosed or by the time they're done with radiation for sure, have seen both a speech and language pathologist and a lymphedema therapist stakeholder. So the question then becomes, how do we take that message home to all of you? And the answer is, you come from all kinds of places. Some of you are in major academic centers. Some of you are in small towns. What I've learned, having traveled the country on this topic, is that actually in some small towns, they do this quite well. And in some academic centers, they don't. And so everybody has the opportunity to go back and assemble the cast of characters at a place like Tumor Board, or even just turn to the radiation doctor that you work with, or the surgeon or chemo doctor, and say, in a bit of a rhetorical tone, is it appropriate that we make sure that every one of these patients sees a speech pathologist and a lymphedema therapist? And the answer, of course, is always yes. Everyone wants this for the patients, but whose job is it to actually make sure it happens? And like Brooke said, the answer is all of us. So once we all agree, which everyone does, that these 2 things are important, and the answer about when is as soon as possible, meaning before or during treatment at the latest, not 6 months after treatment, that's too late. Then it's just a matter of connecting the dots. And so the other take-home message is, find out who in your ecosystem is the best speech and language pathologists, or the group that is the best, and find out who's invested in head and neck cancer. And the same is true for lymphedema therapy. There's always somebody, even in a small town, you'll find people who are saying, yes, I see this, and yes, I'm the person who these patients find their way to me eventually, and I take care of them, and then put them on your speed dial. In my office, our medical assistants know this. Our nurse practitioners and PAs know this. Our surgeons, med oncs and rad oncs know this. Our residents know this. And so it's automatic. I would also say that on the last day of a radiation treatment, the patient should walk out of the office with an appointment to see the speech therapist and the lymphedema therapist within a week. Now, where do we add onto this also pneumatic compression? Well, the pneumatic compression is its own journey that runs alongside this. Of course, the lymphedema therapists are front and center and talking about how important pneumatic compression is and how good it is relative to self-MLD at home. So they are delivering this message of, here's your take-home homework, use the tactile flexi-touch. But because there's some insurance processes, because the team has to come out and measure the patient, educate them, teach them how to put on the garment, wait for it to be delivered, and then come back and deliver it and so forth. They don't deliver it, but they come to the house and teach you how to put it on and so forth. That takes a little bit of time. So that lead time happens in best in show right around the time we identify a patient. So as we present in the tumor board, we've already got referrals in the system for speech pathology, for lymphedema therapy, and we've notified our tactile person. Actually, my tactile person is Skylar, and I think she's on the line. So Skylar knows as early as possible, and that gives us an opportunity to make sure that we're moving at the right direction at the right time, so the patients are getting what they need when they need it. Some people might ask, when's the best time to start using a tactile flexi touch? And I would say is as soon as possible once the treatment is done. Most people by a month post-treatment are quite comfortable wearing it. Sometimes the skin's a bit angry during radiation in the first 2 or 3 weeks. But the bottom line is to get on that and to get moving as quickly as possible. If you're one of those people who wants to stop and screen, then you can do that as well. And there are many different screening tools out there. Here's an example of one. You can cut and paste this one. We're happy to share it with you. Just take a picture of your screen. But it could be any of these things or all of these things. But this goes back to that critical question of who has lymphedema. I can tell you the vast majority of them have lymphedema. And when I say vast majority, we're talking about 90 or 95% or higher, especially when we're talking about patients who are coming through 6 weeks of radiation. So that's on the topic of screening and monitoring. Brooke, did I leave anything out?
No, I don't think so. I think you hit it right on the head. And like you mentioned, the prevalence data that came out from the Genes publication says that 96% of these patients have lymphedema. So to sum up this section, really, if you can do one thing, start screening for symptoms within your clinical practice. Encourage someone on the team to be asking patients about the symptoms they're experiencing, and just know that a high prevalence of these patients are going to develop lymphedema. So, if we can all take ownership of doing something to help really promote prevention and earlier intervention, these patients will see a lot more success in the long run. So with that, I think Caitlin's going to take over to ask some Q&A.
Yeah, thank you both so much. So kind of shifting gears here, we are going to walk through 5 of the most common questions that come up in our head and neck programs across the country. So this first question, we'd love to hear from both of you. When is treatment not viable? So an example is the patient, they will not get better.
Brooke, you go first.
Okay, so I did sort of discuss this a little bit earlier this evening. In my opinion, there's no set time when a patient, quote unquote, will not get better. I get this question all of the time, especially on social media. Maybe they've got a patient late stage, 10 years out from treatment, and the clinician will reach out to me and say, according to the literature, treatment is moot. It's not going to work. What are your thoughts? And my opinion is, if we can even help alleviate even just one of the multitude of issues that these patients are dealing with, then that's a win. In my own treatment, I've seen patients 5, 10, 15 years out that do have external and internal fibrosis. And if I would have followed the literature that, this is their new normal, they wouldn't have seen success. But I've actually had patients that are that end stage, that do get better, that do get off of feeding tubes, that are able to resume somewhat of a, general diet and thin liquids. That being said, it's important to, set precedents with the patient that this is an investment. When the lymphedema is at that end stage, there will be a lot more work and burden management in the long run for both you as the clinician and the patient. And we do have to set expectations about that so that, they are aware and engaged with at-home therapy in addition to what they're doing in the clinic. But in my opinion, it's always worth a shot. And I think that patients deserve to have the information, like I said, to make informed decisions and to help reduce their burden management.
Yeah, I think, everything you said, Brooke, really covers this whole question. I think I've never met a rehab provider that says, I'm giving up, you're not going to get better. It's just not in their vocabulary. And that's a good thing. These patients are suffering. Somebody that comes in 6 months post-treatment and can't get off their feeding tube, or somebody who's 12 years out and has lost a lot of weight and is aspirating like crazy and has all that fibrosis. People like Brooke make a big impact in these patients' lives. And so we have to find the SLP and we have to find the lymphedema therapist and we have to get them into treatment, and they do get better. I'll tell you that the flip side of that, the idea of abandoning a patient or saying, you're not going to get better, is devastating. And head and neck cancer is the highest in terms of suicidality and depression of all the cancers in the body. And so we can never give up on this population. And that's just not just saying things in the wind. We really do improve their outcomes when they sit down in front of somebody like Brooke, who can look at their swallow, look at their lymphedema, and address both.
Absolutely. Thank you guys both for answering that. Brooke, this next question is for you. This is one that is common across the country. Many people think SLPs only work on speech and swallowing. What are the biggest misconceptions you encounter when it comes to SLPs managing head and neck lymphedema?
Yeah, so this is a great question and one that comes up frequently and has come up in my own practice, that the speech pathologist should not be involved in lymphedema care. However, when you look at the scope of practice of the speech pathologist on ASHA's website, one of the aspects of continuum that we are supposed to have a role in is prevention and wellness, which, if we've said anything this evening, it's that lymphedema is extremely important in not only prevention but wellness for these patients. And we know, as speech pathologists performing fluoroscopy and endoscopic studies, that the underlying pathophysiology for many of these patients is lymphatic in nature. So I would argue that SLPs play a vital role in that. And in addition to swallowing and airway management, our studies such as video fluoroscopy and endoscopy can actually help elevate the care of the physical and occupational therapist, because we can use that imagery and quantitative data such as what Jessica published in her study, as well as other measures, to demonstrate that what our colleagues are doing is helpful and effective.
Very well said. So Dr. Carney, this is a question we hear from clinicians, just that some clinicians assume internal swelling after cancer treatment is just normal and it's a part of the healing process. So how do you explain that the swelling may be lymphedema and not simply normal post-treatment swelling?
Yeah, so there's a bunch of ways we can explain it. The way that I think about it sometimes is that sometimes you'll see two patients, 5 or 10 years post-treatment, both had the same type of cancer, both had the same type of treatment, but one patient's neck is fibrotic and the other one's not. One patient's functioning well and the other one's not. And so what accounts for this difference? And it is usually lymphedema therapy. Now, lymphedema therapy also ties into other things like lifestyle, like, are you eating a healthy diet and are you exercising? So that's also important because exercise is another lymphedema pump that we haven't mentioned today, but a very, very important one. So being rigorous as the fall weather comes in and going out and taking that walk after dinner for 2 miles can make a big difference in how you function the next day in the head and neck space. So these are very, very important. But no, it is not normal to be edematous, but you're after treatment. That there's nothing normal about that. Somebody in the chat box actually asked the question that piqued my attention about, is there a difference between radiation fibrosis and lymphedema fibrosis? And I would say that they're both part of the same constellation of findings. I think we're talking about the same process. It's kind of like having a cold. You've got the sore throat on day 1, and then you got the runny nose on day 3, but it's still a cold. and it's working its way through your body and giving you all these different symptoms. So this swelling is not normal, and we saw data this evening that that swelling can be reversed. Not reversing that swelling has implications. We talked about prevention. And yeah, it's true that a lot of clinicians kind of just wave the hand at this. And that's why we're here tonight, to address that.
Mm-hmm. Agreed. This next question, Brooke, you answered pieces of this, but as an SLP, what is the timing for requesting a referral? When do I send my patients to a CLT that treats head and neck? And when do I refer for a advanced pneumatic compression device?
So as you mentioned, I talked about this briefly earlier this evening, but in my opinion, at the time of cancer diagnosis is the time of referral to the speech pathologist and to a CLT. So at a former cancer program that I was the district lead at, when the patient was diagnosed with cancer, I was automatically consulted. I would come in behind the radiation oncologist. I would give education and counseling. And if the patient was open to it, we'd get them immediately set up for an MBS and fees, as well as a referral to CLT. So that is, I think, should be the gold standard. As Dr. Carney mentioned, there are not a lot of CLTs throughout the country, nor speech pathologists throughout the country that maybe are paired up at a lot of these centers. But I do think that each of us on the team can take ownership, for pieces of this. So if you are a PT or an OT on this call, I saw in the chat that people were saying, I don't have an SLP, what should I do? You can partner up with your physician colleagues, your ENTs, your rad oncs who are doing surveillance scopes. Ask them if you can see those internal images. To see, if what you're doing is effective, which, as Dr. Carney said, if you're using manual therapy and FlexiTouch, then you will have an improvement in internal standpoint. So I think, there are workarounds, and it's not perfect access at this point, as we all know, but the earlier we can get involved, the better.
Mm-hmm. Thanks for answering that. So last question, either of you could answer. So a common myth is that compression alone will solve lymphedema. So how do you explain the importance of specialized therapy and pneumatic compression as a multi-modality treatment plan in addition to the traditional measures?
So I'll jump in, and then Brooke will catch what I missed. I think this goes back to that slide earlier. Lymphedema care without speech therapy care is a fail. Speech therapy care without lymphedema care is a fail. And lymphedema care is best done by a lymphedema therapist. When a lymphedema therapist sees a patient, examines their neck, examines their mouth, starts to ask the right questions, he or she will see things that that others don't see. It's a discipline in and of itself. Now, some speech and language pathologists are also lymphedema therapists, so you've got you've got people who've got tremendous skill sets and can add those two things together into one visit. Pneumatic compression is the take-home homework. Pneumatic compression is the device you use when you're home as an adjunct. So best in show would be to do pneumatic compression as your take-home homework, but to see a lymphedema therapist who's really the teacher, the one who's educating you about the process, assessing your skin, assessing your progress, doing the education, doing some self-MLD and visits, and is really the quarterback of the lymphedema side of this process. So I think it's really ideally all three. It's that speech and language pathologist, lymphedema therapist, and pneumatic compression at home that really makes a big difference. I sat across from a physician about 2-3 years ago, and it's a doctor, not an ENT doctor, not a cancer doctor, who went through head and neck cancer treatment and did it exactly the way we described it here. And when I told him that in the last good study on this, only about 5% of head and neck cancer patients get all of this, meaning that they get some of this kind of best in show multimodality therapy, he was shocked. And he says, I couldn't have made it through without all of these ingredients. And so the goal is to bring all those appropriate providers to the table so that the patients can get this good care. One of the questions, I'm going to spring one on you, Caitlin, just because I'm on a roll here, but one of the questions that came up was contraindications to treatment. And I see it in the Q&A box, and that one always comes up. There's not really any contraindication. I think there's always going to be some concern with an open wound, for instance. If you have a free flap that was done 2 weeks ago, you're going to want to talk to the doctor, the surgeon team before you put on a pneumatic compression device. That's a no-brainer. Open wounds is a big one, but there's really not any absolute contraindication to this device. And I think it's important to know. The other question that comes up when is the best timing to start? And the answer is, by a month post the last day of radiation, they should have the device on, which again means we have to start the process even earlier. So either at tumor board or at the first radiation doctor visit or in their post-op surgery visit, wherever you are along the journey of patients' care, the earlier the better to notify your tactile local team that there's a patient coming through the pipeline and we need to start the process. All right, back to you, Caitlin.
Thank you. If we can go to the next slide. So we are going to transition to our payer questions. Karen, thank you again so much for being on and with us tonight. So these are 3 questions that we have gathered from clinicians across the country. The first one is for you, Karen. What are some best practices for documenting symptoms of patients with head and neck cancer-related lymphedema?
Yeah, so I get this question a lot, and what is really essential is to provide a comprehensive overview of the patient's clinical needs, like specifying the type of cancer diagnosed, date of onset, noting conservative therapies previously attempted, and identify those persistent symptoms that remain despite those therapies and that warrant that at-home pneumatic compression use. The details really matter. So detailed documentation of symptoms, particularly aligned with anatomical locations, as well as quality of life changes. That type of documentation will significantly aid in securing reimbursement for the prescribed device.
Thank you. This next one is a good one. So can you touch on why qualification for a FlexiTouch for a head and neck patient requires the qualification stated at the beginning of the program?
Yeah, sure. So all patients require a diagnosis for their prescribed device, and then nearly all insurances require standard conservative therapies to be tried first. And then the 3 most common of those are compression, exercise, and elevation for at least 4 weeks. If symptoms persist after this period and the patient's prognosis supports that at-home treatment, then qualification may be considered. But now the type of pump for which a patient qualifies also depends on the severity and characteristics of their symptoms. So for patients who need a FlexiTouch, it's necessary to document why a basic pump may not address their needs. So for instance, maybe they need programmability for certain pressures, or because they're required to retreat the head and neck region, or maybe if decongestion is needed in the chest before done in the head and neck.
Thank you. This last one is common, and we do hear this quite often. So what if my patient cannot use compression? Maybe there's pain, fear, inability to don or doff related to range of motion. What would you suggest?
Yeah, this is a good one too. So if the patient encounters barriers to conservative therapy, such as compression, it's not just an end game. So what needs to be done is to document the obstacles thoroughly. So just clearly describe the patient's reported challenges and detail your assessment based on their account. So in some cases, the barriers may be very straightforward. Like for example, the inability to apply or remove compression due to the presence of a trach. But now, if there's no reference to the trach in the records, just be sure you're jotting that down and explaining that barrier.
That's very clear. Thank you so much, Karen, for being on. We appreciate you. All right, so I am going to go to the Q&A here. Brooke, this first question is for you. How long after radiation is completed do you feel comfortable completing fees? And they said our facility attempts to obtain baseline fees prior to start of cancer treatments, but scheduling constraints can be challenging for these patients. So what would you recommend?
Yeah, that's a great question, Donna. So as you mentioned, baseline imaging is really important. So if possible, get that baseline MBS or fees. However, after treatment concludes, I would say to perform a follow-up fees as soon as the patient is able to tolerate it, and that really will just be patient dependent. In addition, using your clinical judgment and assessing risk versus benefit and really where the patient is at. But typically, I try to get that follow-up fees done as soon as possible after treatment, as soon as they can tolerate it, just so we know where they're at post completion.
Thank you. This one is a good question, one I have not seen. This could be either for Dr. Carney or for Brooke, does the SOZO have any ability in the head and neck cancer space?
Brooke, I know little about this one. Maybe you know.
I actually do not think that it does. That would actually be a great question for Helen. I don't know if she's on this call or not. But my understanding from a few years ago is that it does not. But that's a great question from Claire. So I will get more information and get back to her. My understanding, like I said, from a few years ago, though, was that it was not applicable, but we'll find out more.
Yep, absolutely. Let's take one more here just because of time. So Brooke, I think this would probably be best for you. If a lymphedema practice does not have an SLP on the team, could this be done remotely by other SLPs?
Yes, so I responded to this person directly, but to answer as a larger group, the SLP can provide some services via, teleservices. As I mentioned in the chat, I've consulted on a lot of patients throughout the United States remotely just to provide further insight. However, the imaging that I mentioned, so video fluoroscopy and fees, that has to be done in person. And for the SLP to really help guide care, those studies will need to be conducted. So yes and no. And the other, question that person asked was, what should we look for hiring a speech pathologist? So, competency and MDS and fees. And then, of course, if I had my wish list, it would be, they had training in manual therapy, they were familiar with lymphatics, they had oncology, rehab, understanding, and were also trained in cough rehabilitation. But at baseline, if you could get somebody that is competent in MDS and fees and is open to learning and collaborating in oncology rehab, then you're, going to be good to go.
All right. Well, thank you both so much for being on. This presentation was excellent. I have just a couple of closing remarks here. So Tactile Medical will send a follow-up email containing a feedback survey, as well as that criteria reference that I showed at the beginning of the webinar. And a recording of this webinar will be uploaded to tactilemedical.com. So if there's any clinicians within your practice or outside of it that you think this would be beneficial for, please feel free to share it. And then lastly, we do have Breast Cancer Awareness Month coming up in October, and we are offering several webinars. So you can go to our website and find those. So with that, I will close out. I just want to thank you all so much again for your time, for your engagement, and we hope that you all have a wonderful rest of your evening. Thank you and take care.